It was Hippocrates who realized the association between seizure and psychiatric symptom long back. And Hippocrates basically perceived these behavioral problems and epilepsy to be the same entity. And what he told is that when it goes in the direction of the body, it manifests as epilepsy. And when it is upon the intelligence, then it becomes melancholy. So Hippocrates perceived this psychiatry and behavioral manifestation of epilepsy long back. So here is the relevance of why this program have been arranged and why the diverse number of professionals have been gathered in this discussion. The points are, see, persons with epilepsy, it's an extremely common psychiatric symptoms. It's a very common association. And along with seizure control, they heavily impact the quality of life of the persons of epilepsy. And it increases the mortality, including suicide risk. There are lots of key pharmacological interactions and implications of epilepsy surgery. And with the advancement of technologies and greater precision of localization of seizure foci, the implications of epilepsy surgery has increased to a large extent. And it's the time for all the professionals of this field to work in integrated way so as to enable our patients to get the highest possible facilities. So here the context. The focal seizure, usually why the psychiatrists and diverse number of professionals need to see it frequently, that I'm telling. The focal seizure sometimes can be mistaken for psychiatric presentation like panic attack, dissociative experiences and all. And sometimes psychiatric symptoms may resemble seizure that we call the psychogenic non-epileptic seizures. And this psychogenic non-epileptic seizure may occur in persons with epilepsy too. So in both the situations, it may happen. And many psychotropics reduces seizure threshold. And the patients used to get the concurrent medications for both the conditions. And psychiatric patients may present with seizure, like in glucose dysregulation, alcohol withdrawal, recreational drug use and all. So there's a bidirectional relationship between epilepsy and psychiatric comorbidities. And some AEDs are associated with development of psychiatric symptoms that I'm going to elaborate later on. And while some anti-epileptic drugs are found to be having the positive effect on our moods and also psychiatric symptoms. Some focal seizure or some specific locations may mimic some sorts of symptoms that I'm going to tell you. Is that in temporal lobe seizure, actually visceral sensations like nausea, palpitation, hallucination, illusion, affective symptoms, anhedoid state, altered sense of time, derealization, depersonalization, déjà vu, déjà vécu, déjà pensé, absence, vertiginous sensations, transient amnesia are usually associated with temporal lobe. Focal seizure arising out of temporal lobe. Then frontal lobe, when the frontal lobe, it may manifest as non-fluent dysphagia, impaired comprehension, focal areas, word ejaculation, absence, and concurrent seizure in parietal and occipital lobe may manifest in the form of pins and needles, tingling, numbness, formications, and visual seizure like darkness, sparklings of flashes of light, then momentary blindness, and frontal and temporal lobe, concurrent involvement of the frontal and temporal lobe. It may manifest as automatism, repetitive movements like lip smacking, complex behavior like walking around, undressing, turning pages, driving, violence and aggression. All these things may manifest. Those symptoms may mimic as psychiatric symptoms. So the association, now I'm coming in precisely with the association, what we can see is that mood, anxiety, psychosis, and ADHD and autism are relatively frequent comorbidities in epilepsy. And traditionally, these were considered to be the complications of seizure. Previously, it was thought that these are the complications of seizure, but now a bidirectional relationship has been demonstrated in so many studies conducted across the globe. So, in association, patients with epilepsy at greater risk for developing these psychiatric disorders. And the disorders would be the mood, it could be attention deficit, autism that I already have told, and this suggests there is the existence of a common pathognomic mechanism, or it could be a common neurobiology that may lie underneath these conditions. And alternative explanation could be this epilepsy and psychiatric illness are the result of an underlying structural brain abnormality. It could be in very minute level, or it could be in gross level. So the prevalence of psychiatric disorder in epilepsy, there's a lifetime prevalence of depression and anxiety at 30 to 35% of the patients. I'm going more elaborative way in my subsequent slides. So it seems that personality-related problems is very high in what we call the viscosity of personality, and paranoid form of psychosis, hostile belligerence, and all these things are very much associated. Now, viscosity personality we call when the persons repeatedly used to talk in very restricted topics. And apart from that, the suicidal behavior, depression, affective symptom, hypomanic episode or manic episode, interictal psychosis, post-ictal psychosis, apart from the anxiety and depression that we are getting very commonly in persons with epilepsy. Okay. So there's a bidirectional relationship. There's a bidirectional relationship between epilepsy and psychosis. And epilepsy is associated with psychiatric disorder. And you see how the links are going on. Some AEDs, anti-epileptic drugs, may precipitate psychiatric symptoms. And I'll be precisely defining few of the anti-epileptic drugs, which are the most notorious ones that are associated with psychiatric disorder. And as epilepsy is associated with behavioral problems, psychiatric problems, so patients used to take the psychiatric medicine. And the psychiatric medicine may cause decrease in seizure threshold, and thereby precipitating seizure. Or this psychotropic medication may have a very strong interaction at pharmacokinetic level. And thereby it may very seriously impact the actions of AED, and AEDs again the AEDs may impact the action of antipsychotics or other psychotropic medications. So this comorbid psychiatric disorder is the result of an increased psychosocial problems, and so here we need our psychiatric social workers or medical social workers to be with us if you are really intended to give the best care to our epilepsy patient, or if you intend to minimize the socio-occupational dysfunctioning at all, because epilepsy is the most stigmatized illness in human history from the beginning till date, and it is still regarded as one of the most stigmatized illness. It causes huge impairment in day-to-day functioning, or the patient has to take so many precautions. His profession may change. If he is a driver, he has to change his profession. He cannot run heavy machineries and all. Even if he is on AEDs. So repeated seizures actually increases the vulnerability of psychiatric disorder. If the seizure is poorly controlled, seizure is not controlled well. And psychiatric disorder increases the vulnerability of the epilepsy. It is vice versa. And both the epilepsy and psychiatric conditions are caused by brain abnormalities, either in the gross level or a very minute molecular level. If we want to categorize the psychiatric manifestations of epilepsy, then if we like the spectrum of the illness, the anxiety disorder, panic attack and all, it could be affective symptom, it could be unipolar depression, it could be bipolar disorder, patient with manic episode, hypomanic episode, depressive episode, and psychosis. And psychosis could be post-ictal, interictal, and usually they used to develop the schizophrenia-like of psychosis, schizophrenia spectrum of psychosis. So here is one study conducted in 2017. This is a meta-analysis of 27 studies actually, and total 3,221 persons with epilepsy were tested. And in the pool prevalence of the anxiety and depression disorders of 20%. So it's a Canadian study, and the sample size is very satisfactory. It's more than 30,000 subjects. And here, the lifetime prevalence of psychiatric morbidities in epilepsy were tested. And it is seen that this manodepressive disorder was associated in persons with epilepsy mostly, then anxiety disorder, mood disorder, suicidal ideation, and any other psychiatric disorder with more in persons with epilepsy. These are UK population-based study. Sample size is not that much of big. These are the Indian studies actually, and sample size were very less. And in India, actually, we are lacking some integrated these sorts of studies encompassing large number of samples. So risk factors for psychiatric disorder in epilepsy, we would like to say that when it is intractable epilepsy and frequent seizures, and symptomatic focal epilepsy, temporal lobe epilepsy, early onset epilepsy, perceived seizure severity, then polypharmacy, social handicap, and adverse family background, and these conditions actually makes the person more vulnerable to develop psychiatric illness. So depression, as I already told, the prevalence of mood disorder is almost like that in Canadian Community Health Survey, and prevalence of epilepsy is higher in patients with mood disorder, that is also seen, and it includes both unipolar, bipolar, suicidality, and the lifetime prevalence was 10 to 25%. And depression was 3% in persons with epilepsy and uncontrolled seizure. So here is the cycle of the depression. So stressors causes stressor, medical illness, family discord, workplace problem, all these things could be a stressor. And these stressors causes the thoughts, the negative ruminations, low self-esteem, hopelessness, helplessness, all these sorts of feelings, and these causes the behavioral symptoms like social withdrawal, lack of motivation, decreased activity, and ultimately starting into low energy, seizure, and effects of AEDs are being place. So how we can diagnose depression in and you see in our the practice we use the Beck Depression Inventory, Hamilton Depression Rating Scale, or SCID is the structured clinical interview for DSM disorder, and NDDI. So I'm going to be elaborating with this scale actually. This is called the Neurological Disorders Depression Inventory for epilepsy. So this is a very simple and very easy to administer and very effective. And 2 years back already, AIMS has formulated its Indian version, and they have a study with a very big sample size. Department of Neurology, AIMS, has validated this Indian study. So this is very simple. Actually, this is very simple. These are 6 questions that we have to put forward in front of our patients. And these are rated as rated 4 when the symptoms are always, and 3 when sometimes, rarely, 2 and never for 1. And the scoring more than 10, more than 10 is taken as would be to be interval. And this is the patient feels everything is a struggle, and he will feel that nothing he does is right. Feeling of guilt, and feeling of suicidal, like it would be better to be dead. Feeling of frustration, and difficulty in finding pleasure, that we in psychiatry we call it anhedonia. This is adopted for neurologists to administer in all the epilepsy patients while evaluating. So now coming to the treatment actually. So it's a very important point that 80% of the patients with epilepsy are not screened for depression. And screening for depression is a very simple step. And anhedonia, that is the inability to experience pleasure. And there could be some iatrogenic factor like recent discontinuation of AEDs or recent introduction or dose increase of an AEDs or forced normalization. So risk factors for AED-induced depressive episodes, that is the personal or family history of mood disorder, anxiety, alcoholism, polytherapy, rapid titration, and high doses. So there is a misconception in the mass, and that is that all the antidepressants significantly lower seizure threshold and should be avoided, but the fact is not like that. There are some antidepressants that definitely lower the seizure threshold that I will be elaborating in my next slide. And lower doses of antidepressant may in fact have some anticonvulsant properties. And the best SSRIs are the citalopram, escitalopram, fluoxetine, fluoxamine, paroxetine, sertraline are unlikely to worsen the seizure frequency. And but we should avoid bupropion, mepirocillin, clomipramine, and amoxapine. Actually, they lowers the seizure threshold or have the strong their interaction. They can pharmacokinetic interaction at the pharmacokinetic level. They are the strong enzyme inducers, and they may accelerate the metabolism of AEDs and thereby making the person vulnerable for seizure. So treatment guideline for depression. The SSRIs are the first line of treatment for both for adult and children, though it is associated with sexual dysfunction and weight gain that is to be taken care of. And SNRIs, duloxetine, venlafaxine are also safe. Then tricyclic antidepressants are not recommended as they cause weight gain, they cause sexual dysfunction, they act on the cardiac conduction, may cause QT prolongation and exacerbates memory dysfunction, increased risk of seizure. They are also notorious for drug interaction, along with some symptoms like dry mouth. They may precipitate glaucoma. They may precipitate urinary retention in elderly individuals. And mouse are monoamine oxidase inhibitors are not often prescribed. So in pharmacotherapy, we can go for, as I already have told, and how long we should treat a case of depressive disorder. Actually, usually for full response, it could take 6 to 12 weeks of time, and it is to be continued for 4 to 9 months after the patient gets symptom-free, and gradually tapering the dose. And simultaneously, we should go for the cognitive behavior therapy and the psychotherapies. And for treatment, stage 1 monotherapy with SSRI and CBT is recommended, and stage 2 monotherapy and simultaneously another SSRI, and combination therapies if the patient is non-respondent. So 4 common disorders in persons with epilepsy, anxiety disorder, you will find that is the generalized anxiety disorder, panic disorder, phobia, and OCD is unknown. There is no such studies in this area. And anxiety disorder commonly coexists with depression. There is a 70% of the cases it gets a mixed anxiety depression. So clinical aspect, it could be peri-ictal, ictal, or post-ictal, interictal also. So ictal anxiety is the fear, the most common psychic aura, especially for the right temporal seizure, may not resolve after insection. And so treatment principles say to avoid AEDs having the propensity to induce anxiety, and patient may develop anxiety when we withdraw or taper the dose of anxiolytic AEDs, like all those AEDs that acts on benzodiazepine receptors. Then we have to keep in mind about the drug interaction, the phenomenon of drug interaction. We should know whether these, we should study the physiology very well. We should know whether it's ital or perital. And is there a risk factor other than epilepsy? Is it anxiety disorder alone or coexisting mood disorder? That is also to be ruled out very, very precisely. So we can treat generalized anxiety disorder with SSRIs, especially paroxetine or escitalopram, with benzodiazepine, clobazam. Simultaneously, it dissolves anxiety and it also an anti-epileptic. Then beta blocker like propanolol. And AEDs with anxiolytic effect like sodium valproic acid, tigabin, barbiturates, gabapentin, pregabalin, or oxcarbazepine. These are the very novel anti-epileptics that can be that is having the action on both the condition. And non-pharmacological treatment like family counseling, supportive psychotherapy, psychoeducational programs, and all these helps to achieve counter anxiety or depression. So panic disorder, there are several FDA-approved medication like sertraline, paroxetine, clonazepam, alprazolam, valproic acid, oxcarbazepine, etc. So here I'm coming to the treatment of psychotic disorder. Actually, these psychotic episodes may beget psychotic episodes, and periictal psychosis it hampers the optimal seizure control. And antipsychotic medications like risperidone, quetiapine, but we should avoid clozapine and olanzapine. And clozapine is significantly, it reduces seizure threshold. And in our literature, it has been mentioned that more than 600 milligram or plasma level of more than 0.6 milligram per liter is prone, the situation is prone to induce seizure. And recent literature suggesting we should add lamotrigine if we go for a higher dose of clozapine. So, prescription of lamotrigine along with clozapine is advisable to avoid clozapine-induced seizure. And in case of epilepsy, we should be more cautious while using clozapine. And then positive symptoms, negative symptoms, we have to choose accordingly the best of the best antipsychotics. So the need of treatment of comorbidities in epilepsy, why we should be very cautious and why we should treat all these conditions. This presence of psychiatric comorbidities complicates the management of epilepsy, first of all. Say, for example, a patient of depression, patient of epilepsy having depression. So what will happen in that condition is that patient will be helpless, hopeless, and he will be starting non-compliant to the medications. He will be having no will to live, and he'll be so lethargic and all. So it's a very important dimension, important aspect to get the compliance and to get better seizure control. This treatment of the psychiatric comorbidities in epilepsy is very important. So it is recommended to identify the factors responsible for psychiatric comorbidities. And psychosocial issues are very important issues as the stigma and getting socio-occupational dysfunction, getting restriction in his activities and all. And so the psychosocial issues is to be better taken care of. And we should also take care of the adverse events due to AEDs that I will be elaborating in my next slides, and all those neurological factors, neurobiological factors associated with seizure. So management of depression and anxiety epilepsy and factors to be considered for antidepressant therapy. Drug interaction we have to take care, and as I already have told, SSRIs are better tolerated. So the need to treat the psychiatric comorbidities in epilepsy. There's the management of psychosis in epilepsy. There's a very important part. Like antidepressant therapy, the factors to be considered for antipsychotic therapies that we have to take care of the pharmacokinetic and pharmacodynamic interactions, the impact of seizure threshold. And few antipsychotics are known to be and found to be lowering the seizure threshold, and we should avoid that, and we should choose a very novel antipsychotic. And dose of antipsychotic should be tailored as per the patient response, and there should be frequent consultation. And we should avoid the enzyme inducers like clozapine that reduces the drug level of anti-epileptics, and exacerbation of adverse event of antipsychotics due to AEDs should be carefully monitored. And antipsychotics at higher doses may increase the risk of seizure threshold, and usually would be initially myoclonic type of thing. Then EEG changes have been reported in 4% of the patient at therapeutic dose of clozapine, and this fact is to be kept in our mind. And atypical antipsychotics like risperidone, quetiapine are preferred because of their better tolerability and safety and less association with seizure threshold or drug interaction. So this is a very important area. Now I'm going to talk about the epilepsy and suicidality. And it encompasses the completed suicide, suicide attempt, and suicidal ideation. And more frequent in epilepsy versus general population. And what I mean the 11.5% death in chronic epilepsy patient is suicidal. And 3 times suicidal death is consistent with epilepsy diagnosis. And there is a bidirectional and 5 times high risk of suicidality in epilepsy patient. And history of attempt is very important predictor. Previous attempt of suicide, and there's a 34.8% attempts and later become successful suicide completer. And comorbid psychiatric disorder increases up to 14% risk of suicide. That is, if it's a mood disorder, then it is 32 times, and its anxiety, it is 12 times. So risk is greatest at first 6 months following the diagnosis of epilepsy. That we all should keep in mind that that suicidality is very strongly associated with persons with epilepsy. So it's a study of JAMA Neurology, the risk of unnecessary mortality in people with epilepsy. In this population-based cohort study of 50,000 people with epilepsy and 1 million matched individuals without epilepsy were identified, and 2 data sets from the general population of England and Wales. So people with epilepsy were significantly more likely to die of any unnecessary cause, unintentional injury or poisoning or suicide, than the people in comparison of the cohort. So opioids and psychotropic medications were more commonly involved than anti-epileptic in poisoning, death due to poisoning. So this is the premature mortality in epilepsy and the role of psychiatric comorbidities in a population study. So here, patients with epilepsy were identified through National Population Register in Sweden, and any inpatient and outpatient with the diagnosis of epilepsy between 1954 and 2009 is a very epic study. And the patients were compared with age matched with sex with general population. So it was seen that suicide was associated with psychiatric disorder and epilepsy. The suicide was very high. Coming into the middle, here is the non-epilepsy and psychiatric disorder. And the first one is epilepsy but no psychiatric disorder. So persons with epilepsy and psychiatric disorder are more at risk for committing suicide. Okay, this is standardized mortality ratios for death by suicide. So here it is high for post-temporal lobectomy, followed by post-epilepsy surgery. So these 2 conditions are strongly associated with suicidality. It is followed by the temporal lobe epilepsy itself. So temporal lobe epilepsies are more very strongly associated with suicidality than other. Okay. These are meta-analysis that the risk of suicide ideation, attempts, and death in person with epilepsy. And the study included more than 1 lakh population with persons with epilepsy and more than 7 lakh controls. And there was a positive association was found between epilepsy and suicide attempt. So overall rate in persons with epilepsy is 5 times higher than the general population. If I talk about precisely about the suicidality, and 25 times more in persons with simple partial seizure of temporal lobe origin, to be precise. And there is psychotic symptoms, borderline personality disorder, psychosocial factors and stress, physical health and morbidity, comorbidity, access to means of attempting suicide, and family history of psychiatric morbidity, male sex. These are all strongly associated. So here is the question remaining, the assessment and risk of AEDs, but significant only with adding. Skipping this slide. So this is the recommendation. So identify the psychiatric disorders and how we're going to manage. And neurology is not expected to manage the psychiatric manifestations of epilepsy. And most frequent associated risk is that current or past history of mood or anxiety disorder, if there is, we should elicit. And family history of mood or suicidal behavior, etc. This is another important point. Then past suicide attempts and document assessment. So now I'm coming to the last part. The program is going so exhaustive I can comprehend. Thank you very much for bearing with us. So relating the psychiatric disorder to epilepsy and focus on AED therapies. The psychiatric and behavioral changes have been reported in 17% on patients with AEDs. The fact is that the epilepsy itself causes psychiatric illness, and again, anti-epileptic medications causes psychiatric illness. That is the double. And irritability was the most commonly associated, reported behavioral changes with anti-epileptic therapies, while depression was frequently occurring psychiatric changes with anti-epileptic therapies. So irritability, aggression, tantrum, other behavioral problems, depressive mood, psychosis, and anxiety, suicide thought, these were found. And it's in another study reveals the same sorts of finding. So how this happens, basically the carbamazepine, lamotrigine, lacosamide, oxcarbazepine, valproic acid, topiramide, phenytoin, they all, I'm talking about all those anti-epileptics having their action on sodium channel. This increases the plasma sodium level and thereby increases psychosis. Then carbamazepine is also having, and lamotrigine, phenobarbital, oxcarbazepine, phenytoin, and levetiracetam. And again, they causes a blockage of the voltage-gated calcium channel. And this causes disruption in calcium hemostasis and ultimately increasing the risk of depression. And among most of the anti-epileptics, actually, I'm precisely pointing out this levetiracetam was strongly associated with behavioral manifestation, and it was low with the valproic acid. So here, when a neurology should condition that neurology should treat, and when the neurology should refer the patient to a psychiatrist, actually. So this is a very exhaustive slide. It has been prepared after testing so many literatures. That is the major depressive episode neurologists can treat. Neurology can treat dysthymia also, minor depressions also. But a neurology should refer a case of epilepsy to a psychiatrist when there is suicidal ideation, to be precise, number one. And there is psychotic symptoms. First, it could be fast-track symptom. It could be positive symptoms. It could be negative symptoms. And there is any smell of bipolar disorder. There is, if there is a chance of hypomanic or manic episode, any history of hypomanic or manic episode, or there is recent symptoms of manic or hypomanic episode, then it is to be referred to a psychiatrist. Then mood disorder that fails to remit after 2 optimal trials of antidepressant, when the patient becomes non-responder. Depression case, a case of the depression, minor depression or dysthymia, when the patient is not responding. So ultimately, the main goal is to improve the quality of life, and that's what I'm telling you. That living with epilepsy is about much more than seizure, and what we have seen in this discussion. So for people with epilepsy, the disorder is often defined in practical terms, such as, say, for example, challenges in school, in education, in profession, uncertainties about social and employment, because the patient is subjected to so many restrictions. He cannot drive, he cannot go alone, he cannot run the heavy machineries, and ultimately unemployment situation, all these situation occurs, and his independent living is impaired because it is advisable not to go alone while the water near fire that we conventionally advise our patients. So at the same time, they are faced with healthcare. This is the most important point, because in our community, in our scenario, this healthcare delivery system is very fragmented. Even the state-of-the-art institutes, and you think about for the general population or suburban areas, because epilepsy is so common. It is the 1% of the world population, so it's a huge. And 15% the chance of lifetime prevalence is around 15%. So it's a very colossal number of cases, always remains in the society. And majority of the cases cannot access to the well-structured, well-coordinated healthcare delivery system, where a patient can have a consultation with a neurologist, a neurosurgeon, a psychiatrist, a psychologist, or a psychiatric social worker. So these are valproic acid and epilepsy comorbidities. So, sodium valproate and valproic acid is a combination. As we know, it is the FDA approved for migraine prevention also, apart from its first-line anti-epileptic medications. And about 50% of the patient achieve more than 50% reduction in headache frequency. This is another dimension of this novel molecule that I am talking about. And it is approved as monotherapy for acute mania and bipolar disorder and maintenance phase of bipolar disease also, simultaneously being a very novel anti-epileptic medication. And it is also approved as combination therapy for acute bipolar depression. So here I'm talking about the mechanism actually. These are psychotropic effects. All those GABA mimetic anti-epileptics like barbiturates, benzodiazepine, valproate, Bactrin, tiagabin, gabapentin, and all. Actually, these are sedating, these are anxiolytic, but these are depressogenic also. But these are again these are anti-manic, and another group, these anti-glutaminergic drugs. These are activating, these are angiogenic, and again these are antidepressive like lamotrigine, felbamate, etc. So in activated patients, these cause positive and negative actions. So psychiatric risk of anti-epileptic drugs in patients with pre-existing psychiatric problem, that is everything converted into table, and that is dysthymia. So phenobarbital, then bizavetrin, topiramate, diagabin, they causes the major depression. So paranoia, agitation, hypermotor, dysphoric mood, learning disabilities are associated with this lamotrigine or levetiracetam. And most importantly, I want to highlight is that all the anti-epileptics are causes learning disabilities. Actually, I am talking about, I am concerned about all those childhood epilepsies. Where there is a very, and the entire spectrum of anti-epileptic causes the learning disability. And so while managing a case of childhood epilepsy, this is very much important to keep psychologists, psychiatric social workers, etc. in the team for better response to the patient. So there are few novel anti-epileptics like carbamazepine, I should say oxcarbazepine, valproate, and lamotrigine, and these are anti-manic and very beneficial in bipolar disorder and mood stabilizer. So I'm coming to conclusion. So in the summary, what we have seen is that the risk of psychiatric complications with AEDs is likely to be linked with severity of the epilepsy, polytherapy, rapid titration, and high doses of drugs. And patients with previous psychiatric problems or familial predisposition seem to be especially prone to behavioral adverse events. So it is important to recognize patients at risk in order to inform them, their families, and about the possibilities of psychiatric adverse events, to use a careful titration scheme and make sure that the patients are seen frequently. Then when recognized in early stage, the psychiatric complications are mild and reversible in the most. So risk factors for psychiatric complication are not strict contraindication for any particular drug, and it is not always necessary to withdraw the responsible drug completely. So depending on the pathophysiology and severity of the symptom, a dose reduction or a combination with other neuroleptic or antidepressant medication is a good act. So behavioral side effect profiles, both negative and positive psychotropic effects, should be considered in the choice of the optimal drug for an individual patient. Thank you very much. And the house is open for discussion. I have seen Sadullah Da, Nazim Ahmed, Divjuti Bora.
Dr. Hamid, can you please unshare your screen so that
yes, I am unsharing. Yes.
Thank you. First of all, Dr. Borkotuki have made a very nice comment to you that it is an excellent presentation. We should form a combined committee of neurologists and psychiatrists for discussion on such common issues.
Yes,
so I request, sir, if you can make some comments, sir, Dr. Borkotuki.
Thank you so much, Rezaul, for your excellent presentations. And it's very nice to see you after such a long time. And it is a very, it is a very important topic actually. We frequently ignore the associated psychiatric complications in patients with epilepsy. Actually, all the epileptic patients, they should have a common treatment first by the neurologist, followed by the assessment of a clinical psychologist or psychiatrist, and they should have been treated by them also. But frequently we ignore. And this practice, I think we should rectify as soon as we find, personally me, if I find that any patient, epileptic patient is having some major depressions, not to talk about the suicidal ideation, immediately I refer the patients to a psychiatrist because it is a very frequent comorbidities. Anxiety, of course, anxiety and minor depressions are very common in patients with these epileptic patients. And actually, I really grateful to Rezaul for such a lucid presentations. You make the things so simple and very nice presentation. Rezaul, God bless you.
Thank you. Thank you.
Sir, we have Dr. Roy, Dr. A.K. Roy from the very beginning, and he made a comment that he wanted to enjoy your presentation. So any comment, Dr. Roy? You were there from since beginning.
Yeah, Dr. Rezaul, it was really very interesting, very informative, and it's just a simple way you have described everything. Okay, I was very impressed with your presentation, really. Okay, and be a psychiatrist, sometimes very difficult to diagnose, like whether it's a dissociative disorder, it's a epilepsy and all. No, so the thing is that, so when to refer to whom? That is the question actually. Like suppose, okay, so like you said, suppose any patient is coming to you, and suppose I'll diagnose that after this test and all this and that, you've been suffering from epilepsy. Definitely patient will go into depression. Oh, I'm suffering, because nowadays social stigma also there. Once he's suffering from epilepsy means is a long-term treatment, lifetime, whether I'll be cured or not. So definitely they will go into depression. So the thing is that, sir has already commented about that. So when there is a depression with suicidal ideations, it's a neurologist's duty also to refer to the psychiatrist. So the vice versa. So the question now to the psychiatrist, some of the dissociative disorders, so many presentation this and that. So when we should refer to the neurologist?
It's a very important question, you see, and we all should comprehend our territories. Every epilepsy cases is to be attended by the diverse number of professionals, but I should say, literally, officially, it is recommended to work in a very coordinated approach, not only to the neurologist. The patient needs to be attended by psychologist and psychiatric social worker also, and also by a neurosurgeon. You see, with advancement of technologies, the chances of epilepsy and the possibilities of epilepsy surgery, better seizure localization has increased to a large extent with functional MRI, then PET scan and all, pinpointing and localizing the area and excising it.
So there is a question. There is a question in the chat box from Dr. Shourabh Bardoloi. He's actually asking for the role of valproate in how, especially in bipolar mania. Role of valproate in bipolar mania.
Yeah, it's a very very nice question actually. You see, this is the time-tested mood stabilizer, sodium valproate, and it has been used as mania as a control of all those manic symptoms. If I should like to say, racing thought, flight of ideas, psychomotor agitation, and all these symptoms of mania are well controlled, and it also counters the patient. It also safeguards the patient from going into the depressive phase. And why these anti-epileptics works in this psychiatric condition is that in literature it has been seen that this manic episode or these things are some subthreshold. There are some subthreshold discharges. Subthreshold discharges in the temporal lobe is found to be consistent with the manic symptoms. And so, first of all, it is a time tested. Then the physiological mechanism that I have told, that manic episode is a kindling phenomenon in the temporal lobe. And so these validates the rationality why these anti-epileptics are effective in bipolar mania. Excellent presentation. We should form a combined committee of neurologists and psychiatrists to discuss this issue. Yes, this is very important, and I am very much optimistic and hopeful with this. And this is a very promising thing that so many professionals have been gathered, though in less in number, and we should take it to the mass. This effort should be taken to the mass, and we should always we should have frequent sit-ups and share our progress. Especially psychiatrists will be sharing the progress in psychiatry. Neurologists will be sharing their progress of their field. Okay. Role of valproate. So the questions are attended, I suppose.
Yeah. So, sir, I think there is no as such any questions.
Okay. Anyway, we can go to the vote of thanks.
Yeah. So, Doctor, thank you very much for your lucid presentations, and also you have, had a good discussion actually post meeting, and it's a very important topic that you have given your deliberation. Thank you very much, Doctor, for the same, and thanks to all participants who have actually spent their valuable time with us and actually listened this presentation. Sir, we in Sanofi, one thing we want to tell that we are actually doing this kind of program quite often, since it's a pandemic situation we are going on, and probably in future also we have to do this kind of program quite often in this year itself, because we don't know what the color we are going to see in the third wave. But yes, in person, we will going to meet you in person very soon. Already our colleagues started visiting you already in person. But as per the program is concerned, especially this scientific fest or these events are concerned, we always encourage this kind of forum only, where probably you need not to travel, but sitting at your home, you can actually enjoy the academics, which is very important. Our brands are very much available, Doctor, across each and every corner of the country, be it Solian in psychiatry, be it Depakote XL in psychiatry, or Halper in chrono, or maybe Frisian. All the brands are available. So apart from that, we have many other brands are also there, like which are also life-saving brand like Cardes, Amaril, like Lantus, Lacilactone. There are many brands out there. Even in the COVID-19 pandemic, Dexton is one product which has been approved as one of the protocol drug. So that is also belongs to Sanofi only. So all the brands are available. So if you are facing any challenges related to our brands, so our colleagues are there. So please be in touch with our colleagues. Our colleagues rather will be in touch with you, so that there should not be any challenge to get our brands. With this note, I thank you very much once again, Dr. Rezaul, and thanks to all respected participants for your valuable time. So stay very safe and healthy. Wish you a very nice time ahead. Good night, doctor. Thank you.